Welcome everyone to our, I believe, third session in IBD educational series run by Lyfebulb in partnership with many thought leaders and patient advocates. My name is Karin Hehenberger. I'm the CEO and founder of Lyfebulb. And really the goal with this educational seminar series is to bring to you, to patients, knowledge and inspiration and motivation to do better and to learn more about your own conditions. We're focused on inflammatory bowel disease, and that includes Crohn's disease and ulcerative colitis. And I'm really happy to be joined here today by my co-moderator, Dr. Joel Bauer, who will be presenting and introducing our speakers. Welcome, Joel, or Dr. Bauer.
So I'm Joel Bauer. I'm a professor emeritus of surgery at Mount Sinai School of Medicine. And on the panel will be Dr. Stefan Holubar, who's a surgeon now at Cleveland Clinic, who is an expert in inflammatory bowel disease surgery. And also Tina Aswani Omprakash, who is actually a patient who is working, I guess, on her master's in public health, if I'm not mistaken. And, I think to start, what we're going to do is divide the session. It's a half-hour session. We're going to divide it into talking about ulcerative colitis and about, then the second half, we'll talk about Crohn's disease. So the first question for Dr. Holubar is, when is surgery indicated in a patient who has Crohn's disease?
Thank you very much, Dr. Bauer and Karin and everyone at Lyfebulb for allowing me to participate today. So, Dr. Bauer, to answer your question, when is surgery indicated for patients with ulcerclitis, there's basically three main times. The first, which is the most severe, is what's called acute severe ulcerclitis, and that's when a patient is hospitalized with a really severe flare, and they're on high-dose steroids and typically get some rescue therapy these days in the form of infliximab therapy, and they're still not getting better. I think the important point for patients who are hospitalized with severe ulcerclitis is they can't stay the same and they can't get worse. They have to get better. And if they can't get better with medical therapy, then they have to get better with surgical therapy to get out of the hospital. And ultimately, sometimes they have to lose their colon to save their life. That's not the most common, but that's the most dramatic. The most common for about 80% of patients is what I call, what we refer to as medically refractory ulcerclitis. And these are patients who are out at home in the community and they're on chronic medical therapy, but they're just not responding to it well enough. They're having too much bloody diarrhea, they're losing weight, and they're not thriving. They're not leaving the house because they're agoraphobic, because they are having to move their bowel so many times. And they're really just refractory to all the modern medical therapies that our IBD gastroenterologists have. And that's the majority of the patients fall into one of those two categories, but most of them will be, at home, suffering not quite silently, so to speak. And then the third category is patients who have a colorectal, what we call neoplasia associated with ulcerclitis, which is typically either dysplasia, which is precancerous cells, or unfortunately, sometimes colorectal cancer.
So, the most common indication is medically refractory disease. Okay, so if you're involved with a patient as a surgeon, how do you convince them, or actually are you dealing with the gastroenterologist as well, probably, to convince them that the medications aren't working anymore and the patient needs surgery, but you still need the patient's consent for that?
Yeah, it's a great and subtle point, Dr. Bauer. You can't convince them. All you can do, is provide them, the information as part of an informed consent process with a thorough discussion. And they have to make that determination for themselves ultimately, because it's their life and it's their colon. I think, people, my fellowship training at Mayo Clinic, I was taught that it's kind of like a ring of fire. People don't want to walk through it because they're scared of walking through that portal, but they don't realize that once you get to the other side, it actually is not as bad as you might think. I'm also fond of telling patients that, this is a short-term investment for the rest of your life, for long-term gain. But, really, it comes down to quality of life. And if you're at home suffering and just not getting better and having a poor quality of life, it may be that surgery can really restore your quality of life and get you back to working and going to school and doing the normal activities of daily living.
So maybe, Tina, we can hear your perspective here as someone who's living with the condition. And also just, again, I think Tina represents beyond her N of one, is a true patient advocate who has started several organizations, among others, Own Your Crohn and also your new organization. So please, I wanted to make sure that people understand it's more than just you as a person that you represent.
Absolutely. Thanks, Karin. And thank you so much, Dr. Bauer, Dr. Holubar. It's a pleasure to be on with you all today. I've been living with inflammatory bowel disease for nearly 17 years now. Originally diagnosed with ulcerative colitis about 5 years in, changed to Crohn's disease diagnosis. And yeah, I've been doing some work in terms of representing, the South Asian population. I have a nonprofit called South Asian IBD Alliance. Prior to that, a blog called Own Your Crohn's, where I've been trying to bring out the fact that many of us are suffering from cultural stigma as well. There's a lot of stigma with a disease like inflammatory bowel disease. And then when surgery might be presented to us, it can be very, very challenging. Dr. Holubar, Dr. Bauer, you make some great points about how this can be very tricky. It was very nerve-wracking for me. I mean, to be told that you need surgery for a condition that you have at the age of 24, where you're going to lose what seems like a very vital organ, your colon, and even parts of your rectum potentially, is, I don't know, it's earth-shattering when you're that age. And I think that can be very, very challenging to digest, literally and figuratively, that you might need surgery. So yeah, I would say it is a very, very challenging next step to make. Now that I'm on the other side, and God knows I've had like so many surgeries at this point, nearly 24, it's been quite a road. But I would say for other patients who might be watching, listening in, that, if you have been told to consider surgery, there's a reason why you've been told that. It is because it could improve your quality of life. And what do I mean by that? Maybe it'll allow you to go out with your friends again, go to work again, go to school again, finish your degree. It certainly has done that for me, being able to, have had surgery that has saved my life, not just once, but many times over. So my doors are always open to talk about this, and I'm happy to turn it back to the physicians here to move us forward in this discussion.
Maybe, sorry, there's a question from the audience.
Yeah.
Related to this. And I think it goes back to Dr. Holubar and Dr. Bauer, as well as you, Tina. Who makes the decision? Is it the patient or the gastroenterologist when it comes to going for surgery?
I think it's a partnership between the surgeon, the gastroenterologist, and the patient. And I will say that both Dr. Holubar and I are in tertiary referral hospitals, and by the time the patients got to us, unless they were admitted emergently with a megacolon or perforation, they had researched this and were very knowledgeable about the medications that they were taking and whether they were working on. Are there any other medications that they could go to? And then they were pretty knowledgeable about the surgery. So I think it's a tripart partnership between the surgeon, the patient, and the gastroenterologist. You can't have the gastroenterologist say no and the surgeon say yes, you need surgery. Everybody has to come together on that. Do you agree, Stefan?
Yeah, I agree completely, Dr. Bauer. It's a partnership. These decisions are not taken lightly, and they're not made in isolation. The way we practice inflammatory bowel disease medicine in the modern era is in a multidisciplinary format, where the gastroenterologist partner with the surgeon, with the IBD surgeon, and of course with the patient and their families. And it really is a great example, if not one of the best examples in medicine, of shared decision making, because like we said, you have to provide the patients and the families the information and the knowledge to make an informed decision. I think the thing I'll add these days with social media is that there's, these fantastic professional patient advocates, like Tina, for example, is a great example of that are out there and available to answer questions. And there's other people, Effortless Alyssa is another one that comes to mind, who's on Instagram. And I know that these kind of people are willing to share their experiences. I think the one thing, there's a very good J-Pouch forum on Facebook. The one thing you do have to keep in mind with social media is that sometimes people who are really suffering and having complications are the ones that are spending a little bit more time on social media, and they're looking for support and look for answers and solutions to their problems. So the newer patients, who are facing surgery need to keep that in mind, that everything that they read can be overwhelming and scary, frankly, but it is enriched a little bit for the people who need it more.
Stress one thing, because I see most of the questions were submitted. It's called J-Pouch as surgery. The surgery that really cures the disease is the colectomy, taking out the colon. The J-Pouch is the way to avoid a permanent stoma. So I've had patients, and I know you probably have too, who did not want to have a J-Pouch. I will say that we were in a position where that was not common, because they were mostly coming to me and maybe to Stefan because they had seen a local physician, a local surgeon, who was willing to do the colectomy and give them an appliance or an ileostomy, and then they sought further consultations. I think now, though, that a patient who is contemplating having a colectomy, they know about the goods and the bads about J-Pouches, and that's much easier to convince them now. Are there any patients, Stefan, who cannot have a J-Pouch?
There are, in order to have a good J-Pouch, you have to have a good anal sphincter mechanism, and you have to be overall pretty healthy, because these days, most commonly, we do it in 3 steps in a 3-stage surgery, where first we remove the colon and get the patient healthy and off the steroids and reverse the anemia and reverse the malnutrition and let them get some quality of life back and, get their strength back, basically. And then once they're recovered, typically no sooner than 3 months later, we can go ahead when they're completely healthy and do the J-Pouch. And as you know, the J-Pouch is a very complicated thing to construct, with a lot of staple lines, and it's got a higher leak rate than others more simple, less complicated operations. So we almost always most commonly will make a temporary diverting loop ileostomy, and then that closure surgery is done 3 months later. So first of all, you have to be physically fit enough to be able to undergo 3 surgeries, and then you have to have a really good, functional anus, because you don't want to connect the J-Pouch, which is part of the small intestine, to the anus, and then be incontinent for diarrhea all the time. So that would be a disservice to the patients. Those are the biggest categories. Over the years, I have seen patients who, for lifestyle reasons, they don't want to have to move their bowels 7 to 8 times per 24 hours. It's usually 7 times per day, plus or minus 1 at night. For example, the people that come to mind are like truck drivers or highway workers, or people who just have some kind of job where they don't have regular access to a bathroom. And it's not that you necessarily have urgent need to go to the bathroom, but you do need to go regularly. And those are the people, as well as people who just don't want to have 3 surgeries. They just want to have one and done and have everything removed and live with ileostomy, or they're extremely risk averse and don't even want to, risk the 5% pouch failure that's typically quoted in most large volume high center studies.
Yeah, I would just add to that to answer some of these questions that have been coming in regarding who makes the final decision on whether to try another medication or move on to surgery. I just want to stress here the importance of a shared decision. Nobody can force you to have surgery or try another medication, but at the same time, as a patient, we need to be understanding of what could happen with the time lost. There is a time and a place for surgery, and I want to make sure I emphasize that. I waited until it was too late. I had a lot of pressure from my family not to undergo surgery, not to try medication. It all goes back kind of culturally for me. But waiting too long meant worse outcomes for me. I went from 135 pounds to 85 pounds in a 6-month period, and then lost my colon in emergency. You don't want this to become an emergency situation, because what that means, like Dr. Holubar was saying, is can you actually go on to have these surgeries and repair that malnutrition? It might take longer than the 3 months. And, multiple stages obviously need to be involved to help you recover. But timing is critical, I think, when it comes to deciding about surgery. I know there's a zillion new medications out, but if you are worsening, it is imperative for you to talk to a surgeon, because sometimes trying to bring you back from a really bad state is something that can take forever on medications. And I think we really need to discuss the timing aspect of things.
That's a good point, but most of the surgeons who do this surgery realize that if you have a patient who's sick, who has gone from 120 pounds to 80 pounds, that person is not a candidate to have the operation in one stage. That person should have a subtotal colectomy, which is, just removal of the colon, leave the rectum behind, and then you have time. You can wait 3 months or longer, whatever it takes for that patient to be nutritionally stable, and then you can go ahead and do the pouch. Now, we did pouches in one stage where we did the colectomies. And those people were sick, but they were not terribly sick. So I think there are the staging of the operation, whether you do 1 stage, 2 stage, or 3 stage, is every surgeon who does this operation knows about that. So you're absolutely right, Tina. You cannot let the patient get so ill that they perforate, and then you're really you're exposing them to a lot more risk. But you do have the fail-safe that you can do a subtotal colectomy and then wait as long as it takes to do the pouch. I just want to, what are the downsides, Stefan, of doing a pouch? What are some of the complications of doing pouches, J pouches?
Well, the pouch is it's not a gimme. It's a complicated thing. In particular, we talk about removing the colon is relatively straightforward. And depending how sick they are, hopefully the safest of the operations, but removing the rectum is a bit of a bigger deal. I'd say generically for any, major abdominal pelvic operation, the surgeons are concerned, everyone's concerned about infections, bleeding, and damage to other organs or nerves. Damage to other organs or nerves is typically from prior surgery, from scar tissue. And these days we try to use as much laparoscopy and robotics as possible, but there can still be scar tissue. The bleeding is not typically a huge issue. Infections can be an issue, especially if the patients are heavily immunosuppressed on chronic steroids for a very long time, because the steroids do inhibit wound healing. The two big kind of complications that happen in the short term after any of the 3 surgeries, if you do a 3-stage, is one is an ileus. It's called a paralytic ileus when the small bowel goes to sleep. That's always temporarily. It's typically short. Sometimes can be a couple of weeks, but that's less common. But it almost always, if not always, gets better by itself if that's really what it is. And then the big major one, which is really when somebody online asked about, pouch failure, probably the biggest reason the pouches fail is because of an anastomotic leak. And that's where the pouch is joined to the anus, doesn't heal properly in about 5% of cases roughly. And then they may need to be more operations in order to repair that pouch leak, in order to salvage the pouch and allow the patient to have a chance at a life without an ileostomy. The other thing is that if you do have a pouch, we talked about the functional aspects of having, the increased bowel movements, typically without blood or typically without urgency. But pouchitis is a concern, and that's kind of like having mini ulcerclitis or like a flu or cold of the pouch, whereby you have a little bit of urgency and you have some urgency and diarrhea, and you have to see the doctor and get a pouchoscopy. And typically the vast majority of cases of pouchitis are self-limited, meaning you get a short course of oral antibiotics and then it goes away, and it's not a constant chronic thing. However, we don't really do that many pouches for patients with Crohn's disease. Specifically, we only do pouches for Crohn's disease that's limited to the colon and the rectum, and not in the small intestine and not in the anus with fistulas, because fistulas, as Tina might be able to talk to you from a patient perspective, are, very damaging to one's quality of life. And so that's one of the downsides, is that, there is an opportunity for there to be problems down the road, Dr. Bauer.
I want to touch a little bit on dysplasia and cancer of the colon, because in our experience, 15% of our J pouches were done for either cancer or dysplasia of the colon. And it's a totally different kettle of fish, because one, these patients on average are generally older than, let's say, when Tina had her operation. Because this is really a disease in general of adolescents and people under 40. But there are patients with ulcerative colitis who do quite well for many years with medications, and they have to have very frequent follow-up colonoscopies, and then all of a sudden they'll have dysplasia or a cancer.
What is the percentage, Joel? What's the percentage of patients with ulcerative colitis who develop malignancy?
It depends how long they're going. It used to be said that if you had ulcerative colitis, the risk of you developing cancer in that colon went up by 0.5% a year. That's much less than that now. I would say probably if a person has colitis for 40 years, they have a 15% chance of developing a cancer. But what I wanted to ask Dr. Holubar, are there any patients that you see who have a cancer of the colon that are not candidates for a J pouch?
Yeah, it's a great question. So, it is, I agree that it's about 15 to 18% roughly historically, and perhaps with better medical management now, because it's the chronic inflammation that is kind of like an accelerator pedal on the cells of the colon and rectum to grow. Most patients with colon cancer are a candidate for a J pouch. What we're fond of doing at Cleveland Clinic before, and this is a little bit controversial in terms of getting to the nitty-gritty of the technique, is, we like to do extensive biopsies of the low rectum, because when we make a pouch, we typically do a stapled cuff for about 2 centimeters. We want to make sure that area is clear, and we want to survey that area permanently every year at a minimum, if not twice a year, for the rest of the patient's life, to make sure they don't get a little rectal cancer. The patients who are really not great candidates for J pouches, who have cancer, is typically rectal cancer, and I'm talking about big bulky rectal cancers that are requiring radiation therapy. Now, these days, we give the radiation therapy before surgery, and so you could argue that, well, that rectum is going to be removed and you're not going to use it. But the problem is that the pelvic floor also gets hit by the radiation as a side effect, and that can make the function of having a J pouch in it after radiation not be as good. So the patients may not like the function. So that's a relative contraindication. But it is controversial whether to do hand sewn or stapled pouches for patients with rectal cancer that otherwise would be candidates for high rectal cancer, for example.
Right. So the seminars that I participated in at the major meetings could go on for 6 hours just talking about this. So I think that we've covered more or less the ulcerative colitis, and I think there's a lot more to be said about Crohn. So I'd like to sort of switch over to Crohn's, all right? Because the cancer issue, I mean, we, for example, used to do mucosectomy, take out the lining of the rectum for the most part. We didn't like having the cuff, and there's been controversy about that, but I think most institutions have swung toward a stapled anastomosis, leaving a short cuff of rectum. They're no longer ileopouch anal anastomoses. So, but that's very subtle discussion. So let's talk about Crohn's for a second. So let's start off the same way. When does a Crohn's patient require surgery?
So it's a little bit different in Crohn's because unlike ulcerclitis, when we remove the colon and the rectum, the colorectal, the bowel manifestations of colitis is essentially cured, assuming that is what the diagnosis is, that it actually is ulcerclitis. But for Crohn's, that this is a lifelong disease that affects from the mouth to the anus. And so we reserve surgery until, either to prevent or treat complications that have developed. And if we're talking about intestinal Crohn's, most commonly, that's a stricture, a narrowing of just upstream from the ileocecal valve where the terminal ileum inserts into the colon. That's the area that's the most common operation I do. I'm sure you did as well, is called an ileocolic resection or ileocectomy. So if there's a stricture there, the patient's getting bloated and nauseous, having abdominal pain, this is the most common indication for surgery. And again, if their nutrition is starting to get impacted and they're not able to eat because they're just too bloated and nauseous, then these are the patients we're thinking about doing surgery for. The other kind of big indication for small intestinal Crohn's disease, other than strictures, which is basically a blockage, is a fistula. And that's when there's a connection that forms abnormally between from that terminal ileal disease to somewhere else, usually to a part of the colon or a part of the small intestine or other organs, and that causes pretty severe symptoms and is not going to necessarily respond to medical therapy. What we're really talking about is bowel damage, irreparable bowel damage from the chronic inflammation that's progressed despite the medical therapy.
So Tina, any comments from you here on the surgery with Crohn's disease?
Yeah, I would have to agree with Dr. Holubar here. My Crohn's was primarily located in the colon and rectum, so I actually had my colon rectum removed first, but most of what I hear about is generally the IC valve, that area being resected. Mine was also resected after the fact due to significant disease as well. I think with Crohn's disease, the important thing to keep in mind here is if a patient is considering surgery, always consider, and always talk to your surgeon about, maintaining as much bowel as you possibly can, right? The last thing you want necessarily is, a short bowel syndrome or losing too much bowel, which has actually, from what I understand, that research shows that a lot of this has come down due to a lot of the new medications, maximizing and controlling inflammation so that, only small portions of the bowel may need to be resected that simply are refractory to treatment. So in my opinion, I think surgery has been very much a life-saving option for me. I live with a permanent ileostomy, which is an ostomy bag that is, since I've had my terminal ileum in that area removed, basically a stoma coming out from my abdomen, and that stoma is of my small intestine, and there is a bag over it. I live a full life with my ileostomy. I find that I'm able to do a lot of the things that I used to be able to do and have gained back weight and then some. And I'm able to go to school and do the things that I really enjoy now with an ostomy. So I think it is important to consider surgery, whether it is for UC or for Crohn's, a treatment option for this disease, that we should not look at it as a last resort.
Just Stefan, can you cover a little bit? A lot of Tina's situation is very unusual. I mean, it's not unusual for a surgeon. There's a lot of this, but it's very unusual to have a late diagnosis of Crohn's disease after the colon has been removed and a pouch has been done. You want to talk a little bit, Stefan, about anal rectal disease and Crohn's disease, because that can be devastating.
Yeah, sure, Dr. Bauer. So overall, about 25% of people who have Crohn's disease of the intestines will also get what's called perianal disease. And this is fistulas of the anus. And this is where basically there's glands on the inside of the anal canal that make mucus, and these get inflamed from the immune system attacking it. And then it leads to a tunnel under the skin and stool and pus leaking from inside the rectum and anus to outside on the skin. And these are very difficult problems that are very painful. They're embarrassing. They're very hard to treat both medically and surgically, and really negatively impact patients' quality of life.
So what you're really trying to do, and I'm just sort of putting words into your mouth, you're trying to take care of the local problems by either draining abscesses or doing fistulotomies. And hopefully that will help most people, especially if they're then put on Crohn's medications. And it's very rare that you, as a first step, would remove a rectum for anal rectal fistulizing disease. So
Yeah.
we want to try everything first.
Has there been with the new, sorry, to the doctors here, the new medications that have been more, I would say, targeted and also maybe really hitting inflammation in a way that may be more targeted, have they improved the outcomes for patients like Tina? Because I guess, Tina's diagnosis was maybe 10 years ago, 15 years ago.
Yeah.
Almost
there's no question
17,
that
Yeah.
New medications are excellent for both Crohn's and also colitis, but there are patients that, despite excellent gastrointestinal medical care by
Yeah.
very knowledgeable gastroenterologists who are up to date with the newest medication, there are some people who either are refractory or become refractory
Yeah.
and require surgery. And the first medication, which was infliximab or Remicade, really was developed for anorectal fistulas out in California.
Mm.
And it still is remarkable. It will actually help cure some fistulas, but not all by a long shot. So I think we're actually out of time.
Yeah, unfortunately, this is a really important topic.
So it's a very big topic, and I want to thank both
Maybe we
Tina
can, yeah. Sorry,
If,
Joel, go
if I
ahead.
may make one.
and Dr. Holubar. Do you have any last words, Stefan or Tina?
Yeah, I do. Just to finish out the discussion. So like Dr. Bauer said, if the patients are having perianal fistulas from Crohn's disease refractory to medical therapy, I tell my patients that, a good ileostomy bag is better than a bad colon, rectum, or anus, or even J pouch. And, nobody wants a bag, or very few people do, but it can really give a patient their quality of life back and let them lead, according to the research that we've done in terms of quality of life outcomes, patient-reported outcomes, essentially completely normal life. So you shouldn't discount that if you're really suffering with perianal fistulous disease.
I would have to agree with Dr. Holubar, as a patient myself, and from, speaking to many other patients, really, I think many of us are suffering so much prior to surgery. I was going 30, 40 times a day. This really gave me the optionality to move on with my life and not have my life crippled by IBD. So I would encourage you all, while surgery may not be a cure, it is definitely a treatment option, a way to manage your IBD. It is not something that we, of course, we're afraid of it, but it is not something to be afraid of. It can really give us our lives back. And I do want to make sure we emphasize that today. So thank you for having me.
I would agree with you completely. I guess that's the end of our session. We probably could have a second session sometime later.
Yeah, no, we got a
Covering some of
request
the
from
stuff.
from our audience as well. These sessions are too short. So I want to thank all of you, especially, of course, Dr. Holubar and Tina, to be speakers, and obviously fantastic moderation by Dr. Bauer. But thank you so much on behalf of our audience and the Lyfebulb community. And the discussion can continue on ibdlife.com, where Tina is also a champion and an ambassador. So let's continue. Thank you so much, and have a good evening.
Thank you.
Thank you, Dr. Bauer.
Thanks, Stefan. Thanks, Tina.
Thank you.